So we've been used up to now with the tabular data, right? So we have those relational databases, we have those fields, and then we connect them where this is patient ID here, CMS 1500, UBO4, and CPDP, and we do all that stuff. So we did an interesting project, which is the data comes from a health exchange in New York, and they get the data from about 10 hospitals, right? And so here are different exchanges. We have 60 of them here, and the one we're working on is called HealthFix here in New York, right? It's very hard to get the data. The guys that get the data took 2 years to be able to talk with them, finally, back to synthetic data conversation, like availability of data is very hard. And so the data looks something like this. There are different chapters. So hospital encounter, pathology report, radiology report, discharge summary, consult note, progress notes, and so on, ED, emergency department, and procedures. And then if you zero in on consult notes, you get things such as patient information, the service consultation, and history. And so here's an example of what we're talking about here, right? So you get the patient information, you have patient name, date of birth, and here you go, gender, weight, and blah, blah, blah. You get all that stuff. And then the service is a goals of care, Arabic interpreter, not needed, current, palliative care. Here's the nurse practitioner, and you've got the dates in there, right? So you have the physician and PPA, consult, and then you have a history, 43-year-old women, blah, 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 advanced breast cancer. And this is just one little piece here. So we have the goals of care, and it goes into detail, and the past history. So you have the history, the medications prior to admission, and you can see all that stuff, right? Some of the patients, we had like 500 reports, 500 of those, right? And here's one example from a nurse. Your domain relevant attribute and pattern search, not enough insurance to cover medical expenses, blah, 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 it has to take public transportation. And intervention, ibuprofen, and you hear. So what's kind of jumps at you, different from the physician notes we're using the EMR, you have a lot of the voice of the nurses. And the nurses, as we know, is the most trusted provider, right? Like number one, and the doctor is kind of at the bottom, you know that, right? And so you get, and the nurse spends most of the time, the patient is very close to the nurse. Not so the doctor comes in the hospital like 5 minutes, hey, how are you doing? Check, yeah, good, yeah, bye, right? So the nurse is there, the parent is kind of, oh, I have pain and so on. The nurse is always very close. And they talk a lot, right? So the narratives data, we have encounter, pathology, radiology reports on the patients. And then we have PII and PHI. And for the project we did, we had to have a business associate status because we see the name of the patients and the doctors. So we have clinical information, ICD code, and we got things such as that do not fall in the ICD code CPT for it, kind of something like SNOMED, right? Kind of description, because this is not for sending a claim. It's not to get paid. It's kind of the medical part. So we don't care so much about the. And this one we didn't have patient information. Here you have claims, encrypted patient, which is very well organized. Here, this one is kind of a little all over the place. So one of the things that jump at you is kind of how to combine, because the hospital data, it tells you what's happened in the hospital and what happened to the patient in terms of interaction prior to the hospital. I don't know. You came to the hospital, I tell you what's in the hospital. You get discharged, what happens after that? I don't know, in the hospital, right? So you get a sliver in terms of the patient journey of what's going on, right? So some of the stuff that we were looking at is how to combine the hospital data with PLD data, the narratives data with PLD. That would give you the kind of the fisheye 180-degree wide angle to see what's going on. Yeah, so it's a more complete journey, could potentially answer question, identify patients that are eligible, and sample of merge data may be smaller, right? Physicians are in different settings, so they move from the physician office. I think you were hinting at this, right? They go to the hospital and they come back, so you may be missing those things. And so we worked on, we worked on the HER2 low And HER2 low is a concept that was invented a few years ago. And if you look at the claims, they're HER2 positive, HER2 negative. There's no HER2 low. It doesn't exist in any claims data. And so we had to go to the narratives data to see the HER2 low, right? The HER2 low is written in the text. You have HER2 low. And then you have the other tests that are the amplification and all that good stuff to infer HER2 low. The info is here, but which is not in PLD. So when you have clinically detailed questions, you may want to go to this kind of data because the claims just doesn't capture that granularity, that clinical granularity that we want. So, you know, before ChatGPT, the way to go was the NLP, right? Natural language processing. Yes. And so we ran an experiment that Shanmugam ran. So we asked the system, okay, here's the text, and I am the doctor. I'm telling you what are the rules I use to establish HER2 low. And we asked the NLP, is the patient HER2 low? Yeah, here you're just providing all the information we need. We asked the ChatGPT, what do you think? ChatGPT, no. This is what the doctor is saying he's going to use, but you didn't give me any data at all. So ChatGPT answered like a human being, and the NLP got it wrong. The reason the NLP got it wrong is because it has no memory. It's very short-sighted. It looks at what it's given, but it cannot have a history. So it doesn't understand the quote. So I'm telling you, I didn't say that, right? So quote, but it doesn't understand the quote, or kind of I'm talking about someone, I met someone who I believe said something, and it just goes at the same level. So after this experiment that Shanmugam did, for me, that's the death of the NLP. It's over. I mean, it's... the other one has memory. It can understand quote, kind of, I'm talking about someone talking about this, not you, right? So it's kind of way, way more powerful. So for me, that LLMs just kill NLP in that experiment that we ran. So the other one, and I'll close here, is that the narratives data, this is text, right? So something like ChatGPT, what is very, very good at doing, the LLMs, if I have to use one word, I would call it format. So what the LLM does, it reformats data in another format. One is in English, the other one is in Chinese. It's a reformatting. One is a long essay, the other one a short one. That's called a summary. It's reformatting. Or you can have, fill in the blanks, add the details. This is called expanding the text. That's reformatting, right? So what it does essentially is to take the data, which is text, and put it in a form that you want. And we are interested in tabular data because of a whole history of processing data has been tabular data. So this thing is made for turning the narratives data into tables like fields, right? They can extract the essential, right? Narratives data, of course, has a lot of shortcomings. The doctor or the nurse talks about things they know, and they don't talk about things that they don't know. It's true for all of us, right? We spend time on things that we know, things that we don't know, we just run away from because we feel uncomfortable, or it just exposes our ignorance, right? So it has the biases when you look at and then some people are very, they don't talk too much, and people like me talk a lot, right? So if you look at the physician notes for the same patient, you can get a very terse, kind of telegraphic description of what's happening with the patient, and the other one maybe you get like 3 pages, right? And it has nothing to do with the patient. It has to do with the physician or the nurse that's looking at the patient. So we need to be cognizant of that, right? This is a problem we don't have in the tabular data. Then the question you can ask, so why stop at text? What about audio? Can we do audio, right? And this one, I picked on this one, and this has been approved. It's called the Echo. So it's a stethoscope AI, and it can detect the murmur better than the doctor, right? So this one treats audio signal. And then you can say, okay, what about images, mammograms? And they're doing a very good job. And radiologist, right? It's kind of, I'm not sure if you're like a 20-something, you're a doctor, you want to become a radiologist today. If you become a radiologist, you better be a very good one. If you're a mediocre radiologist, get out of this business. That's not for you. You have to be able to criticize the AI, right? That's your job. If you're coming just like them, you're out of the game, right? And then you can, and then there's another one that I saw was interesting, the video of the they can spot the polyps. I think it's like 99% accuracy on these sensitivity and specificity, that they say this polyp is going to be cancer, right? You have to be careful. So the camera goes in the colon and then we kind of identify the polyps. And so you can see this is really multimodal text, audio, images, videos. And I don't know too much about the tactile. Maybe some of them press, I feel something. The doctor can you cough and they tap on you, right? So I haven't seen anything. It's maybe my ignorance, but maybe they're going that way as well, like tactile to see what's going on. Maybe ultrasound or that kind of stuff. But clearly all that stuff would we just expanded the net. It's not only these tables and the fields and the stuff in SQL or SAS or whatever we use. That's going to be game pretty soon. With ChatGPT turning this thing, annotating the pictures, telling you this is benign, this is serious cancer is happening. You can see that our universe just expanded quite a bit. Yeah, that makes sense. So second, I'd like you to remember is narratives data. So that if you're not looking at narrative, start looking at this. We can start with the physician notes in the MR, but it goes way beyond that. Very good.